the current treatments can't control their symptoms, so that results in poor clinical outcomes and increased costs to them. So that's why I think we need to look at new novel approaches that will cure some of the underlying pathological causes that lead to asthma. So I did some research and I found some promising up-and-coming drugs that could be used to treat some of the pathological mediators. So some of them are monoclonal antibodies that target the IgE antibody and cytokines. Some of them are cytokine receptor inhibitors. Others are signal blockers that disrupt the mechanisms in mast cells. And there's a procedure called bronchial thermoplasty, and I'll go into that later. So the first monoclonal antibody that I looked at was omalizumab. This is an anti-IgE monoclonal antibody that binds to the free IgE that is produced by the B cells. This drug was FDA approved in 2003 and currently is available under the name Xolair. Various clinical studies have been done since it was released to the public, and they have shown reduced levels of free IgE levels in serum and have also been shown to reduce asthma exacerbations. So one of the first studies that was done after the drug was released was in 2004. The researchers wanted to test if patients who were taking the omalizumab drug showed any reductions in their IgE levels. So they did a placebo-controlled randomized trial where they divided patients into placebo group and the omalizumab drug group, and they found that patients who were taking the drug, they had significant decrease in the levels of IgEs in their body compared to the placebo. And they also found that patients who were taking the omalizumab drug showed a decrease in the amount of cells that express Fc epsilon receptors, which are mast cells. So they showed a decrease in mast cell population compared to the placebo. In another study done by Umber in 2005, they were testing if omalizumab had any effect on the exacerbation rates of asthma. So they did another placebo-controlled study, and they divided the patients into placebo and the omalizumab drug group, and they found that after the trial was done, they further divided the patients into two groups. One group was clinically significant was classified as clinically significant asthma patients, and the other was severe asthma patients. The clinically significant asthma patients, they divided them based on their forced expiratory volume rates. So forced expiratory volume is when you forcefully exhale air into the spirometer, and so the severe asthma patients, they classified them because their forced expiratory volume rate was 60% less than the normal predicted value. So they found that both patients showed some decrease in the exacerbation rates, but they found that the patients who had more severe asthma showed much more reductions in their exacerbation rates than the ones that had clinically significant asthma. So another monoclonal antibody that I looked at was lebrikizumab. This antibody binds to the IL-13 cytokine and inhibits its function. As I mentioned, IL-13 is involved in B cell isotype switching to produce IgE antibodies, and also IL-13 is also responsible for inducing goblet cell hyperplasia and mucus hypersecretion. This study has successfully completed phase 3 trials, and I couldn't find the data figure to show here, but overall they found there was a reduction in serum IgE levels, and that the late asthmatic response was reduced by 48%. So now, the other type of drugs I looked at were receptor inhibitors. These inhibit the receptors that cytokines bind to. One of the drugs, it was dupilumab. This binds to the IL-4 receptor alpha subunit on lymphocytes and myeloid cells, and inhibits the IL-4 and IL-13 signaling. As I mentioned in the cytokines section, that IL-4 and IL-13 are responsible for Th2 cell differentiation and B cell isotype switching to IgE. So So the recent study that came out in 2013 was a phase 2 clinical trial, and their primary endpoint result, what they were looking at was if the drug reduced the exacerbation rates of patients who had severe asthma. And what they found was that the patients who were taking the dupilumab drug showed an 87% reduction in exacerbation rates compared to placebo. In the same study, they wanted to see if taking the drug would reduce the IgE levels in the body. So before I explain this chart, I just want to explain how they did their methods. So when they recruited the patients, patients were on therapies such as taking bronchodilators and glucocorticosteroids, and they were told to take the dupilumab or the placebo in addition to what they were already taking. So at week 4, they were told to stop taking their bronchodilators or the LABA, which stands for long-acting beta agonists. And then between week 6 and week 9, they were told to start tapering off their inhaled glucocorticosteroids. So by the end of the study, they were just taking the dupilumab or the placebo medicine. And they found that the patients who were taking the dupilumab had significant reductions in the mean IgE levels in their body compared to the placebo group. Another receptor inhibitor that I found was benralizumab. This binds to the IL-5 receptors on eosinophils, and as I mentioned before, IL-5 cytokine responsible for eosinophil activation and recruitment. So this study that I found, recent study, was a clinical trial, phase 2 clinical trial. I couldn't find, oh no, wait, I did find something. So the clinical trial showed that there was a decrease in the number of blood eosinophils, and the asthma symptoms of patients were improved, and bronchodilator use was reduced in patients. So this is the study that I found. This was done in 2013. So they divided the patients into 2 groups. One group received the benralizumab, a single dose of benralizumab, and a very small dose, 1 milligram, and it was again a single dose. And the other group was further randomized into receiving higher doses of benralizumab. Over a 3-month period, they received monthly injections over 3 months. And what they found was that patients who had the higher dose of benralizumab showed significant reduction in the airway eosinophils compared to the placebo. And while some of the patients showed a decrease in the airway eosinophils with the small single dosage, so ultimately they concluded that the higher dosage was more effective at reducing eosinophil levels than the single dose small dosage. So some of the other types of treatments I found were signal blockers. This one was called R112 inhibitor, and it inhibits the ATP competitive spleen tyrosine kinase in mast cells, also known as SYK. SYK plays an important role in IgE signaling and binding. So this figure is going to focus on this part here. You can see the Fc epsilon receptors where the IgE antibodies bind, and when they bind to the mast cells, this causes a biochemical mechanism which activates SYK, and through a variety of biochemical pathway, it activates transcription factors that basically cause the mast cell to degranulate and release cytokines. So the inhibitor would inhibit the SYK, which would then prevent the biochemical pathway from going to this stage. And so this research that I found was currently in phase 2 clinical trials. But the thing was that they were testing this drug on patients who had allergic rhinitis instead of asthma. But as I mentioned before, allergic rhinitis and asthma are kind of similar in their pathological mechanism. And the results in that study showed there was a significant improvement in relation to less IL-4, less decrease in mast cell population, and lower histamine levels. Another type of signal blocker that I looked at was a drug called mastinib. This is also a tyrosine kinase inhibitor and inhibits the stem cell factor c-KIT pathway that's on mast cells. This pathway is responsible for basically mast cell phase 2 trials were done using this drug, and they showed patients generally showed an improvement in controlling their asthma symptoms. And there was also a reduction in levels of the cytokine IL-4, mast cell population, and histamine levels again. Since this was such a this study showed promising results. It's currently in phase 3 of clinical trials, and study results have not been posted yet, so we'll look forward to that. So this is a procedure that I found bronchothermoplasty is used to treat the airway smooth muscle mass that I mentioned was due to the airway remodeling and leads to bronchoconstriction. So what they do is that they insert a catheter into the airways, airways all the way to the end, distally in the airways. And the catheter has these electrode arms that expand and touch the airway wall, and they release radio energy, which is basically thermal energy. I believe they said it's up to 65 degrees Celsius, which is about 150 degrees Fahrenheit, I think. And what this does is that it reduces the airway smooth muscle mass and basically release some of the bronchoconstriction. And then, so they target an area, and then they keep moving back proximally by 5 millimeters to treat the whole airway. And this could take 1 hour, 45 minutes to 1 hour, this whole procedure. And they also do it in 3 separate procedures, not just one go. So in the first procedure, they focus on the right lower lobe. And when they're done with that, the patient then has to come back next week and undergo another procedure and they work on their left lower lobe. And then a week later, they do another final procedure that the focus of that is the upper lobes. Clinical trials have been done successfully, and they have shown patients have shown improved conditions. The exacerbation rates have been lowered. Trips to the emergency room have also been lowered, and the use of medication has also been decreased by this procedure. And this procedure was FDA approved in 2010, so it's currently in use in many different hospitals, but it's really expensive, so it's only reserved for patients with severe asthma. So a summary, again, as I mentioned, asthma is a very growing concern for the American population. So, and there are several current treatments available, such as bronchodilators, corticosteroids, leukotriene inhibitors. But as I mentioned, these do not cure the asthma, but only control their symptoms. And as I also mentioned, that some patients have shown no improvement using these current treatments. So these are some of the novel treatments that I looked into: the monoclonal antibodies, receptor inhibitors, signal blockers, bronchothermoplasty, several possible future treatments that could be looked into. Maybe they can look into some other, like the pathogenesis, look more into the pathogenesis and tailor medication that is directed towards specific mediators and other types of cells that I didn't mention here. Another possible future treatment could be gene therapy. As I mentioned, that is a newer area of research that scientists are currently working on. So they have already discovered some of the genes that are susceptible to asthma, so they can look more into that and possibly find a cure. So acknowledgements, just want to thank Dr. Luxton for putting up with me and giving me encouragement and helping me through this whole year with this. So thank you, Dr. Luxton. I thank the PCUM faculty and friends for your support, and finally to my family for their love and unconditional support. For the Star Wars. Any questions?
Quick question regarding some of the newer drugs.